None of the authors have any financial disclosures to make. Let's start this video with this intraoperative picture. Any thought about what surgery has been done for this patient and probably what could have gone wrong? This was a case of advanced keratoconus and the patient was scheduled for deep anterior lamellar keratoplasty. After trephination, stromal tissue was removed by lamellar dissection with crescent blade. After the construction of side port, air was injected into the anterior chamber. A 26 gauge needle was used to create a big bubble, but miraculously I was able to achieve only a 6 diameter bubble and my air syringe became empty. It was the first time I was facing this kind of problem. I attempted to inject more air in the same area but didn't succeed. I decided to go ahead with stromal tissue removal with careful dissection. I managed to get the bare Descemet's membrane. After completing the first part of surgery, it's time to move to a simpler part of donor graft placement and suturing. I was so excited to have finished the previous step successfully that I decided to try something new. In place of removing the donor's tissue Descemet's membrane by peeling, I tried pneumatic dissection of Descemet's membrane from the corneal stroma, and this is what happened. The entire donor tissue swelled up because air went into the stroma and the stroma became opaque. Now the simpler step of suturing becomes the most challenging step. The donor tissue was almost double the thickness of the recipient's. The donor host tissue apposition was very difficult. I decided to put tight sutures to avoid any loose sutures in the post-operative period, as this swelling was supposed to go in the post-operative period. Finally, this case got over and the patient did well. The take-home message for me from this case was that no step in the surgery is simple until you do it perfectly. And trying new things is important, but sometimes you can land up in trouble. But keep on attempting. Open sky cataract surgery can be challenging, and we do have small pupils and hard cataracts. This was a case of corneal scar with cataract. A triple procedure was planned for this patient. After removing the recipient's vascularized corneal button, a non-dilating pupil with hard cataract was noted. Even after mechanical stretching, the pupil was not dilating. I thought of using my most trusted device for small pupil cataract surgery, that is Malyugin ring, in this situation. As this was my first case to use this device in an open sky, but it was very simple and I could manage to place it comfortably. After that, capsulorhexis was done and a very big bulky nucleus was prolapsed and IOL was placed in the bag under direct visualization. This case taught me that the devices and instruments are although designed for a particular surgical step or a procedure, but they can be used for other surgical scenarios. All you have to do is to think out of the box. This was a simple but interesting case of intact migration and localized infiltration. The challenge was to remove this ring segment. We have been taught how to place intacts without causing damage to the surrounding corneal tissue, but removing it was a new challenge. A very simple and easily available instrument in our surgical tray, that is Sinskey hook with a longer tip, was used. It was engaged in the dialing hole and the segment was pulled in the opposite direction and along the plane of opposite intact segment. This case taught me that learning how to do something is important, but learning how to undo it is essential. In this case of penetrating keratoplasty, after the removal of recipient's corneal button, I was getting ready to suture the donor cornea. At that point in time, it was noted that something was not right in the intraoperative field. Then I found that donor corneal button was 0.5 mm smaller than the recipient's, which was totally opposite to the principle of penetrating keratoplasty. The donor and recipient's trephine got interchanged. I was clueless about how to proceed further as the backup tissue was not available, and managing with this tissue was the only way forward. I took longer and slightly tighter sutures and achieved proper apposition without a leak. In the end, the donor graft was well attached. This case taught a very important thing, that to avoid surprises and confusion in the operation theatre, Responsibility of checking everything during surgery is yours and not your OT assistant's. Trust your eyes more than your ears. This was the case of repeat keratoplasty. After the trephination, corneal button was removed. Absorbed lens matter was lying loose. I removed it and then turned to pick the donor corneal button and sutures. In those few seconds, I noticed that whole intraocular content was bulging, and before that, I could have understood anything, it started bleeding profusely. To stop bleeding, I decided to place the patient's own corneal button back on the eye and pressed it gently. Once the bleeding slowed, I placed the donor button and tried to suture the graft. Intraocular pressure was very high, so intraoperative mannitol was given, but still 10-0 nylon sutures were breaking and the intraocular content was protruding out. So I decided to use 2-0 sil sutures to close this wound. I managed to avoid the complete expulsion of intraocular contents. This case was an eye-opener for me, that anything can happen in an open sky surgery and you should be ready to tackle it. Such challenging surgical situations can be encountered by any of us. The key is to manage them calmly and scientifically, and always remember that sometimes you win, sometimes you lose, but every time you learn. Thank you.